Hello, my name is Christine Song, and my project title is to cure breast cancer year for the first discovery of a new targeted therapy for aggressive hormonal breast cancer using clinical database and 3D model. The abstract will be talked about throughout the video. Currently, hormonal positive breast cancer boasts a high survival rate, and one of the reasons to think is the tamoxifen treatment, or targeted therapies. And included among the hormonal positive breast cancer is the ER-negative PR-positive subtype. Yet this particular subtype does not receive the benefits of tamoxifen treatment because of its lack of estrogen receptors. And furthermore, the survival rate of the ER-negative PR-positive breast cancer is lower than that of triple-negative breast cancer, which is known to be the most aggressive breast cancer subtype. And even so, there are currently no targeted therapies available for the ER-negative PR-positive breast cancer patients, and this is why my research is vital and absolutely necessary. And here are the 3D tissue culture system that was used in my data. I completed three main types of experiments: database analysis, in vitro experiments, and 3D model. In this figure, this shows the database analysis of the 53,805 genes. In figures 1 and 2, I found through the database analysis of the 53,805 genes, respective of those highly expressed in only the hormonal positive or the triple-negative breast cancer, that there were a 4,319 breast cancer patient sample data set that the ER-negative PR-positive is characteristically more similar to triple-negative breast cancer than it is to the hormonal positive through the gene expressions. In figure 3, I found the high expressions of inflammation-related genes I found last year for triple-negative breast cancer, or specifically CDC20, USP1, and caspase-1. And then in figure 4, I found that these high expressions of the inflammation-related genes were correlated to a worse overall distant metastasis-free and relapse-free survival. Then came the in vitro experiments. In figure 5, I completed a CRISPR-Cas9 to complete a knockout of the ER-alpha gene in the ER-positive, PR-positive breast cancer cell lines because there are currently no ER-negative, PR-positive cell lines available. In figure 6, I found that the knockdown of the inflammation-related genes significantly decreased the ER-negative, PR-positive breast cancer cell growth, migration, invasion, and inflammation-related oncocytokine levels. And then the highlight came in figure 7. I found a new inflammation inhibitor treatment that was successful in decreasing not only the ER-negative, PR-positive breast cancer cell growth, but also the migration when tamoxifen was not. I then used the 3D model for figure 8. I confirmed the effects of the inflammation inhibitor treatment on the ER-negative PR-positive, which proved to be successful, therefore indicating the effectiveness of the inhibitor as a potential targeted therapy because the 3D culture system has a high clinical relevance. So in conclusion, I was the first to suggest the use of the ER-negative PR-positive hormonal characteristics has a close correlation to triple-negative breast cancer than it does to the hormonal positive. And I'm also the first to suggest the use of inflammation inhibitors as a potential targeted therapy for the ER-negative, PR-positive breast cancers. My study suggests the use of inflammation inhibitors as a potential target therapy for not only ER-negative, PR-positive breast cancer patients, but the entirety of the ER-negative, PR-positive breast cancers, such as triple-negative breast cancer and ER-negative, HER2-positive breast cancers. Here are my further studies. Here are my material and methods, my lab notes and data, my research photo. My project was chosen as a presenter at the American Association for Cancer Research. And here are my acknowledgments. Thank you so much and stay safe.